talk follows on quite successfully from Gwyn's one. Gwyn has talked about the World Health Organization safety checklist as it's applied in trauma cases, in major trauma cases. So I'm just going to take this on in a more general way. And I would like to acknowledge some of the content of this course to a number of people from the hospital I work in, and also from George Youngson, former Vice President of the College, who is very passionate about patient safety. Emma Watson, a colleague from Inverness, who provided me with some of the slides, and David Pitts, Education Advisor to the College, who is responsible for one or two of the slides here as well. Well, you know that patient safety is an important issue. In the States, some years ago, they identified in public that there are a number of errors that occur in surgical practice on a daily basis. And that's quite concerning, especially when you think that it's things like wrong side surgery. Now, I would submit that wrong side surgery is an easily preventable, quite a common problem, but it has its casualties, not least the person who suffers the wrong side surgery and then has the complications to bear of that wrong operation. But let's also remember that the surgeon is concerned in this. So you and I, as surgeons, if we are responsible for operating on the wrong part of a person, then we will suffer. And so what we should be doing is trying to avoid that happening at all. So it's about prevention of simple errors. Now, the simple errors are the things that are so barn door obvious that if you think about it, you really do not have any excuse for having made that mistake. And I think that's where we should start. And if we look at these 6 measures, and Gwyn pointed to some of them in his checklist, and checklists vary depending on the circumstance, but here are some. Airway prior to anaesthetic seems an obvious one. Pulse oximetry, is it in place? IV access, prophylactic antibiotics. In my specialty, in Gwyn's specialty of trauma and orthopedics, prophylactic antibiotics are immensely important, and they should be delivered appropriately and according to a fixed timetable. So a checklist is a good way of doing that. Gwyn also mentioned about consent, patient identity, operative site, and the procedure to be done. These are obvious things, and yet if we don't do them properly, then errors are made. And then the surgical sponge count at the end. How often have you heard of somebody with swabs left inside you or missing instruments and they turn up inside the patient? These are 6 things that we could consider for a surgical safety checklist. And of course, as I've mentioned already, checklists do vary depending on the location, but fundamentally they have 3 parts to them. The sign-in, the perioperative time-out check, and then there's the very important one, which is quite often missed, which is at the end of the procedure, which is the check-out or the sign-out process, which is just as important, because at that sign-out process you can identify problems that have occurred during the operation, which you might look out for next time in other operations. So, does it work? Well, you will gather from the tone of what I'm saying to you, I think it does work. And what I'd like to do is quickly review some of the rather old literature now about its effectiveness, and then give you some data from the last 4 or 5 years about how things have been working in the hospitals that I work in. This, of course, is the classic article in the New England Journal of Medicine about the surgical safety checklist, and you'll see Atul Gawande's name there, as well as Richard Resnick. And what they did was they looked at 8 sites across the world, which varied in terms of the type of medical care that is provided, from very basic hospitals up to state-of-the-art hospitals in the United States, and one in London there as well. So the variety of hospitals that was covered was quite extensive. And what did they find? They found that when they instituted the process, the success in dealing with some of the 6 items that we have mentioned already increased tremendously. So airway problems were identified and dealt with and checked appropriately. Oximetry was done better. IV access was improved. Antibiotic delivery was improved significantly, and the identity check, this business about whether or not you've got the right patient, whether you're operating on the right limb, that improved up to nearly 90, well, beyond 92%. And then the counts also improved. But what about the outcome of this in terms of patient safety? And the results suggest that there's a 46% reduction in surgical site infection and a 47% reduction in mortality simply by carrying out a simple checklist. That's quite considerable, and I think it would cause every one of us to think hard about whether or not a checklist improving patient safety is something worth instituting, and I think it is. But that was elective surgery. What about emergency surgery? Gwyn's already told you that it's really important for trauma surgery, but in the same way, and using those 6 measures, they found that in urgent operations, almost every measure improved. Overall complication rates dropped. Death rates dropped by over 50%. Surgical site infections improved, and the incidence of blood loss was reduced as well. Now, this is in emergency operations, and I've heard it said that in emergency operations you can't waste time on a checklist because things have to be done very much more quickly, and it's so important to get on and operate on the patient. Well, I submit that it's so important to get on and operate on the right patient and do the right operation at the right place. And so a checklist is not a bad thing just to make sure that's happening. There's also, more recently, from other places, a recognition that checklists are effective. And in this one, they looked at outcomes of patients over a period of time in a number of hospitals in Holland. And they found that in every single institution, the benefit of the checklist was that the complications did fall compared to before the checklist. So what about how it works in the hospital that I work in? In Scotland, generally, the Scottish Patient Safety Programme had 2 main aims, a 15% reduction in mortality and a 30% reduction in adverse events. And that was the aim when it was set up some years ago. And you will know that mortality in hospitals in the UK was generally coming down. And you'll see from this chart that it was coming down from 1982 onwards. But the key point here is the start of the SPSP in 2007-2008 produced a significant drop thereafter in the mortality in patients in Scottish hospitals. That's across the whole of Scotland. This is the hospital that I work in, and you can see that in the time from December 2007, when the programme started, down to 2011, December 2011, the drop in mortality was of 15%, which is achieving the target that was set. And that has remained at a lower level than was previously since then. Not only was it were we looking at just the death rate, there were other things that were considered. Surgical site infections, the briefings and the pauses. So the briefing is the surgical briefing that you do first thing in the morning, and the pauses that happen before every single surgical procedure. Use of beta blockers, DVT prophylaxis, and glucose control for diabetic patients were also considered. And here are some of the results of the situation in Forth Valley. The surgical briefing. Now, I believe the surgical briefing is a really important part of the surgical operating day because it sets the tone for how things are going to be done during that day. And you can see that the surgical briefing at the start was about 74% of people complied with it. And there was a lot of compliance in terms of turning up but not really engaging. But over time, the compliance did increase. Again, there still continued to be some compliance but not engagement. But overall, things were getting better. It's interesting for me to note, as an aside, that nurses have absolutely no problem with the surgical briefings, the safety briefings. Nurses understand how important it is to get these things right. It seems to be surgeons and sometimes anaesthetists who have a bigger problem. And I think we need to examine our own consciences on these matters, and I'll say more about that later. But overall, there was this 20% improvement in that period of time. The perioperative briefings have, in fact, continued to increase, and now there's a more or less 100% agreement with the perioperative briefings, and they're done regularly. On-time antibiotic prophylaxis. So a checklist is a good thing. You can achieve 100% compliance for antibiotics, for antibiotic administration. And certainly for orthopedics, we are pretty committed to antibiotic administration. But although it's written up, it's not always delivered. But a checklist is a good way of ensuring that it is delivered. And this is to do with surgical site infections for abdominal hysterectomies in the gynecology department. That last tick at the end is not an indication of a massive rise of infections, by the way. It's just the way the Excel spreadsheet goes. But basically, surgical site infections have diminished considerably since the institution of the checklist. So what about the checklist? Who does it? Well, I think I can confirm from you from my personal experience that it has to be everybody in the team. It's not a matter of the nurses doing it or the surgeon doing it or the anaesthetist not being too bothered. And can I also tell you that it includes the student nurse and the medical student. It includes everybody in theatre. Gwyn made a very good point about the porters being involved in this. And I have to say there's a very good logic in having everybody who is involved in the delivery of care to patients, be it emergency or elective, that they should be involved in the perioperative briefings and also in the surgical briefing the first thing in the morning. I can tell you an anecdote about a hospital in Lanarkshire where a locum surgeon turned up to do his operating. And he was asked by the nurse in charge if he would like to be involved in the surgical briefing. And he said, no, it's okay, I don't need to be involved in that. I'll be away having a coffee, just let me know when it's all finished. At which point the nurse closed the book and said, when you come and do the briefing, then we'll all do the operations. So, that was the message that the nurses were giving to the surgeon, who happened to be a locum, that this wasn't optional. It was something that had to be done by everybody in the team. And that's a good message. And that was excellent leadership being demonstrated by the nurse in charge. So there are obstacles to delivering this. People are too busy. I know I've heard that said very often, and sometimes I've said it myself early on, that I'm too busy to do the briefing. I don't think it's too busy to be safe. You're ever too busy to be safe. People do worry about the relevance, and I hope I've demonstrated to you that it is relevant. And I hope I'll continue to demonstrate that during the rest of my talk. Performance anxiety, people worry about whether or not they're going to be able to do it. This particularly applies to the more junior members of the team. Getting people to stop what they're doing, you'll all be aware of in theatres, people are rushing to try and achieve the deadlines. But actually it's good to make people stop, because sometimes the deadlines that they're seeking to achieve are just not the relevant ones. There is a complaint that if you have different surgeons and different anaesthetists, then it makes it very difficult to do a checklist. I would argue the exact opposite. If you're working with different staff in your theatre, then in every way the surgical safety checklist is an extremely important aspect of ensuring that the procedures proceed safely and without difficulty. There is also the authority gradient of a registrar anaesthetist and a consultant surgeon, or vice versa, who pays attention. And I think that's how you set up, that's down to how you set up the business of doing the checklists and how you set the tone in theatre. And if it's all about hierarchy and who's the boss, then it's not going to be successful. But if everybody recognises that safety is a matter of intense personal interest to every single person in the theatre, then hierarchies become less important, and we're more prepared to listen when somebody who might be junior to us in rank and in experience points out something of relevance. even to the extent of a student nurse saying they're concerned. I think we as surgeons have to take it really seriously if somebody says they have concern about safety. How long does it take? Well, it doesn't take long. It takes a while at the start while people get to understand how it's to be done. But once it's embedded in the system, it doesn't take long at all. And in fact, sets the tone very well for an enjoyable day in theatre, because safety is at the essence of and the heart of what you're doing. How to do it? Well, I can tell you that my experience over time has been that the more you forget how important you personally are, the more successful the briefings will be and the safer the process will be. Now, that's not to say you're relinquishing leadership, but what it is saying is that you're allowing other people the freedom to say if they're concerned about something to do with safety. When I first started doing checklists, I used to say, my name's Mr. Ritchie, I'm a consultant orthopedic surgeon. By the time I got to my last list, I was saying, my name's Ian and I'm the surgeon. And so we went around the whole room and everybody introduced themselves on first name terms and said what their job was rather than how important they are. And I think that's the key to making sure that people feel they're included in the process. I also always included in that discussion a statement to the effect that the only reason we're here on this day is to make sure that the patient gets from the anaesthetic room through the operating theatre and out into recovery safely. And that sets the tone for how the whole day is going to go. And I think if you do it in that way, you find that suddenly a lot of the problems that quite often occur in theatres disappear. In other words, this rush to get to the point because the surgeon's got to go somewhere else or somebody else has got to do another thing. The focus of the operating list that day is the safety of the patient. And I think if you do it that way, you'll find it's much more successful. Also more enjoyable. Well, does it work? I feel it does work because it has improved communication within the team. People feel less anxious about saying if they're concerned about a matter to do with safety. Safety has improved. I can tell you that my experience as a surgeon, having done these things in the way I've described, is that I feel more reassured that if anything should go wrong, somebody's going to point it out to me. They're not going to be scared to say it. I think that's really important for patients. And at the end of it all, it's a more enjoyable experience for the whole team in the theatre that day. The problems with trying to introduce it are trying to change mindset. And changing mindset is a difficult thing to do, but it is possible, and you do have to work at it. People complain that it's a tick box exercise, but the point about the tick box of the checklist is that it's getting things that ought to be done without any thought, really, making sure they're done. That gives you a bit more brain power for dealing with the problems. Gwyn mentioned about the difficulties, the perceived or potential complications. You need to think about those things. You've got more time to think about those things if you've done the checklist, which has taken away the routine things that need to be done, that must be done, that are important to do, but you don't need to think a lot about them. It gives you more time to think about more difficult things that might occur. There is a need for commitment by the whole team, and I think you as surgeons and leaders can demonstrate that commitment, and you need to continually refresh the process to make sure that people don't get stale in it. So over time, this demonstrates that there was a time when there was no compliance, as you can see at the bottom blue line there, with the perioperative briefings, rising up to nearly 80%. So there's still way to go back in 2012, and I think things are improving, but there are still people who don't believe that this is the right thing to do. And yet, that's in the face of the evidence about how it improves safety. The question I suppose you should ask yourself is, if you were going to have an operation, would you want to have a checklist done, and who would you choose to do it? My answer is I would definitely want to have a checklist done. I would want the whole team to do it, not just an individual. But if you look at this survey that was done, you can see that the nurses are 100% committed to the idea that patient safety is important and the checklist is important. It's interesting that surgeons are perhaps less convinced, and interestingly, even more so, the anaesthetists are even less convinced. And here's another important one. When you remind other members of the team to carry out the checklist, do you get pushback? The nurses say they do, more than the surgeons or the anaesthetists. So the message there is quite clear. There is resistance to it, but there's less resistance if the surgeon leads the process. So the WHO checklist is good for patients. I believe it's good for the institution because safety improves and your institution benefits from that. It's good for communication within the team. And it's also good for surgeons because safety generally means that you're less likely to appear in the courts answering questions about why things went wrong. Now, just for the last part of my talk, this I think is relevant to the World Health Organization safety checklist. I hope you'll see why shortly. This is what surgeons believe. We believe that we are professionals, that we are excellent, and that we are leaders. Let's look at those words, professional or professionalism, the competence or skill expected of a professional. And the key to quality and efficiency is professionalism. Those are dictionary definitions of the word. But professionalism involves a combination of behaviours, skills, and knowledge. Now, we've just completed examinations that are focused on knowledge and to a little bit about skills and behaviours in order to make sure that surgeons coming through are professional. But this is a slide I picked up on the net about professionalism, and we have to be careful about professionalism. Sometimes it's our appearance and how we portray ourselves that is the cover for the fact that we aren't as professional as we should be. In other words, we don't have the knowledge, the wisdom and the intelligence that supports the appearance portrayed by a good-looking tie. And here's another approach to professionalism. If you're a professional, there are things which you do not believe are your job. And that's some of the things that I come across in the attitudes towards the World Health Organization safety checklist. That's not my job. Well, I would disagree with you. I think as a professional, safety is an integral part of what we're all interested in. And therefore, it is our job to be involved in the World Health Organization safety checklist. What about excellence? The quality of being outstanding or extremely good. That's the dictionary definition. And again, when I was looking around for information about professionalism, I came across this quote from Aristotle. Excellence is never an accident. It's always the result of high intention, sincere effort and intelligent execution. It represents the wide choice of many alternatives. Choice, not chance, determines your destiny. So I think as professionals, if we're going to be excellent, we have to think hard about what we're doing and make the choices that will make the difference. And then there's leadership, the action of leading or the ability to lead a group of people or an organization. As surgeons, we are called to be leaders. That is part of the job that we have to do, and we have to do it well, and we have to do it appropriately. There are different styles of leader, but a medical leader is somebody who is defined by how and what they do, underpinned by why they do it. So the how and the what is how you perform in theatre as a surgeon, and that's not just the operating, it's also things like the safety checklist. And it's underpinned by the reasons you do it. So if your behaviours will demonstrate what it is that you really believe in. And I think we need to think about our objectives when it comes to what we're trying to achieve in theatre and in our professional lives. So let's look at some of the elements of leadership which I think are relevant to the World Health Organization checklist, how you would apply it. There are lots of personal skills that people need as a leader. To identify problems, we do that every day in the sense of identifying people's diagnoses. But how you deal with that and how you resolve the problem, that takes some vision and courage, particularly if you're working in an environment where you have challenges in terms of the resources available to you. Finding creative solutions is another personal skill of a leader, and that needs your ability, your commitment, and your creativity to finding those solutions, and then the drive to implement them. This is one of the slides that David Pitts has in his trainer's course, talking about single and double loop learning. We spend quite a lot of our lives in the first loop, which is where we find a problem and then we fix a problem. So you just go round and round that loop. But at some point, it's very important to stand back and think, so where did that problem come from? So can I fix it at its root cause so that it doesn't occur again? Otherwise, you just go round and round in that little circle in number one. But number two is where you think hard about where it's coming from, what are the problems associated with it. This is one of the opportunities, I think, to use the safety checklist to sit back and look at how you question what's happening when problems occur. And that's the part of the last part of the checklist where you do the debrief and think about how things went that day, what were the problems and how could we avoid them the next time. So when you're just doing the surgery and fixing the problems, that's just doing surgery. But when you're doing the second loop, that is being the surgeon, being the leader, being the clinician, being the person that is making a difference to many people's lives. Then there are other personal requirements. You need determination, resilience, and persistence. And if you meet the resistance in implementing a checklist, then this is where these personal qualities come in, and also the business of managing uncertainty. Other elements of leadership are the interpersonal skills, time to listen to others, trust others to bring solutions, and make space for others to succeed. I think this is where if you flatten the hierarchies, in other words, make less importance about your position as the leader, as the big chief, and make more importance of other people in terms of their ability to help you resolve problems and help you provide good care, then you will be on the way to demonstrating leadership that will change the way you work and change things for the better for your patients. There are, of course, the styles of leadership. There's the cutting to the chase, the man who gets the job done, doesn't matter about the collateral damage. And then there's the other one, which is how does the team feel today, and everybody's very touchy-feely and cuddly. Well, I think there's both styles of leadership are needed, but they're needed at different times and different occasions. And there isn't one style that fits every occasion, and you need to combine these. When it comes to the business of the World Health Organization's safety checklist and how you implement it, it's all about developing teamwork. And I think you will find that if you apply it appropriately, then you will find that teamwork improves. And in this context, the team is the person where the leader is able to relinquish his control in order to allow other people to be the team leader. And I know you've all experienced this in theatre, where you are the leader and you're doing the operation. But there comes an occasion where it's actually the nurse in charge or the scrub nurse who is suddenly the leader, because she is the person that has the solution to the problem that you're facing. And if you're a wise surgeon, you relinquish leadership to that individual. If you're a wise leader, you look around you and find that there are leaders all over the place in your team, and sometimes in the most unexpected places. And the wise leader is looking not just for personal triumph, but it's also looking for the collective success of the whole team. So when you next go into your theatre, look around you and try and work out who the leaders are, and you may well be surprised, particularly if you give them the opportunity to flourish. And I would ask you to consider how it is that you would recognise a leader in your team. So I'm coming to the end now. This is the duties of a doctor registered with the General Medical Council. I have condensed them down into 2 or 3 really important ones. There's a lot of verbiage in this document from the GMC, but the recurring theme is making the care of your patient your first concern and working with your colleagues in the best ways to serve patients' interests. And then remember that little caveat, you are personally accountable for your professional practice and must always be prepared to justify your decisions and actions. Now, if you take those three phrases and then apply them to the business of ensuring patient safety in a theatre, I think you can see that the World Health Organization's safety checklist gives you a way to achieve these three aims from the GMC. So, I submit to you that this is a tool for leaders. It's one tool that you can use that will help you demonstrate that leadership is important to you, it's important to your team, and it's important for patient safety. So, just to summarise, the safety checklist, I believe, is good for patients, it's good for the institution, it improves communication, and it's also good for us as surgeons. So I believe that we as surgeons should demonstrate professionalism, excellence, and leadership in how we apply the safety checklist. And it's a good start to doing that. Thank you very much.